5, 4, 3, 2, 1. Please start, sir. We are live.
Hello, good evening, everyone. It's my pleasure to invite you all, the faculty and the audience, to this Leukemia Updates 2021 CML and CLL updates. I would like to introduce you to the organizing chairperson of the meeting, Dr. Major General B.N. Kapoor, sir, Director, Medical Oncology, Yashoda Cancer Institute, Ghaziabad, and the program convener, Dr. A.P. Dubey, Consultant Medical Oncologist and Hemato-Oncologist, Clear Medi Hospital and Cancer Center, Vasundhara. Without taking much time, I would like to introduce to Dr. A.P. Dubey, sir. Over to you, sir.
Good evening, B.N. Kapoor, sir, and good evening each and everyone, and thanks for taking out time from your precious and busy schedule in this small CME on chronic leukemias. So we'll be discussing talks, two small talks, one on CML and one on CLL, followed by a panel discussion. I would like General B.N. Kapoor, who's I'm so fortunate to have him as my teacher and now chairperson here, to just chair the session. Sir, over to you, sir.
Yeah, thank you very much, Dubey. It's always a pleasure to interact with you and to be a part of a live conference. It's my proud privilege to be a part of this conference on chronic leukemia. And over the year, we have seen that leukemia treatment has evolved over a time. I still remember during the early days of 2000, before 2000, I must say, the treatment of chronic myeloid leukemia used to be only bone marrow transplant, and that too allogeneic bone marrow transplant. With there used to be about 50% mortality. And even when we are fortunate to have HLA matched donor, in 2000, I still remember when Dr. Advani went abroad for ASH conference and came back, and then he spoke about small TKI and BCR-ABL translocation and all that. And then when the Gleevec came, it revolutionized the treatment of chronic myeloid leukemia. Since 2000, many drugs have come, and the treatment has become very easy. The mortality used to be very high, and I must say 50% cure rate. Now we are achieving 100%, and with a small, with only a tablet form of treatment, the chronic myeloid leukemia's treatment has revolutionized. Similarly, chronic lymphocytic leukemia, still, I remember chlorambucil and dexamethasone used to be the treatment earlier, and slowly and gradually we have evolved over the treatment, and now so many ibrutinib and other drugs have come for the treatment of CLL. To deliberate upon all these things and the newer treatment, I would invite Dr. Dubey to kindly take us to the journey of evolved treatment of chronic myeloid leukemia and CLL. So, Dr. Dubey, you're welcome for your talk.
So, good evening, everyone, and thank you, sir. So, I'll be speaking on nilotinib, which is supposed to be a second-generation tyrosine kinase inhibitor being used in chronic myeloid leukemia, a journey of 10 years. So, I'll start my presentation with a small case. This is a 29-year-old female who was diagnosed to be a case of chronic myeloid leukemia based on high TLC. A typical BCR-ABL1 transcript was detected, and surprisingly, no spleen enlargement, whereas in Indian setting, large number of patients, around 90% of the patient will have splenomegaly in CML. And as
sir, sorry to interrupt you, but your screen is not visible. Can you reshare? Yeah, okay. Sir.
One second. Is it visible now?
Yes, sir. Now, okay.
So, I was just discussing about this case, a 29-year-old female who was diagnosed to have CML based on high TLC. A typical BCR-ABL1 transcript B3A2 was detected with no splenomegaly. That was a surprising finding in at least Indian setting, where 90% of the patients who are diagnosed to be having CML are having splenomegaly. And as per risk stratification, she was being stratified as low so-called risk. So what are the problems which are being faced by the physicians whenever we are communicating about blood cancer to our patient in OPD setting? First of all, to communicate a patient about the diagnosis of chronic myeloid leukemia, that is supposed to be a blood cancer, it is difficult for a layman to understand that a patient is having blood cancer, what will be the prognosis of the disease, and also to discuss that, yes, your disease can be very well controlled with the just good adherence to the therapy, and we must assure and reassure that there are many types of blood cancer, but this particular type of blood cancer, that is chronic myeloid leukemia, can be very well controlled with just a tablet per day. And there can also be fortunate setting where a TFR can be attempted in few patients. So what are the consideration for the prognosis of the patient? That whatever TKI we are selecting, there should be at least no risk of transformation to either accelerated phase or the blast crisis, because these two phases, accelerated phase or blast crisis, they are associated with very poor outcome. And also we should know that despite there are first and second generation TKIs, and second generation TKI produce very faster and deeper responses, but overall survival data is similar between the first generation TKI and the second generation TKI, which can be attributed to the fact that because of the normal near life expectancy of CML patient, they have opportunity to have multiple lines of treatment, and to detect those significance differences in the overall survival, it requires a very long-term data. So what are the evolving goals of chronic myeloid leukemia treatment? So first of all, we have to achieve the established treatment milestone like early molecular response and the major molecular response, and to achieve the residual disease, minimal residual disease, and discontinue treatment in a particular subset of the patient who have achieved sustained deep molecular response. And if we are able to do that, and fortunately, then we'll be able to prevent the disease progression and much obviously prolong the survival of the patient. So about this patient who's having low so-called risk, what will be our proposed first-line therapy for this patient? Maybe imatinib or the second generation TKI, nilotinib or dasatinib or bosutinib. So these are the sequential TKI therapy. We have one first generation TKI, imatinib, for which we have very long and very strong data. We have now at least 3 second generation TKI, nilotinib, dasatinib, and bosutinib, as well as ponatinib, which is you can consider as third generation TKI, where the data is not that strong. So what I was saying, that the first priority in our patients of chronic myeloid leukemia is to achieve early molecular response. Why it is achieving early molecular response is critical, because it has been said that the patient who are not able to achieve the BCR-ABL1 transcript copy less than 10% at the end of 3 months, they are associated with the poorer outcomes as compared to the patient who actually achieved the BCR-ABL1 transcript less than 10% at the end of 3 months. So when we see with the second generation TKI, that is nilotinib, we'll be talking about nilotinib, that if you see that more patients, this bar diagram has very clearly very clear and significant differences in achieving the early molecular response in patients who have been initiated upfront with nilotinib vis-a-vis imatinib. You can see that the dark gray are the patients who have actually achieved the early molecular response, that is BCR-ABL1 transcript copy less than 10%, whereas the light gray are those patients who have actually achieved, or that is that is dark gray is the patient who have achieved actually less than 1% of the transcript copy, whereas this light gray is the patient who have achieved less than 10%, and this very light gray is patient who have actually at the end BCR-ABL1 transcript more than 10%. So we are actually supposed to achieve our patient's target goal is at the end of 3 months to achieve early molecular response. As you can see that when we compare nilotinib with imatinib, more patients, significantly more patients, there it is 91% for the nilotinib, 300 milligram twice daily. That is an usual dose in upfront setting. We are able to achieve this early molecular response in 91% of the patients, whereas in imatinib arm, we are able to achieve only in 67% of the patient. And also this response or this incidence of achieving molecular response, early molecular response is irrespective of the so-called risk score. That is, it is as good as in low score as it is seen in intermediate and high risk patients. Now, the cumulative incidence of major molecular response by 10 years, you can see that the patient who achieved major molecular response by the end of 10 years. These are the major molecular response at the end of 5 years. With nilotinib, you can see that 77%, though the incidence or the cumulative incidence of major molecular response plateaued after 5 years, and at the 10 years, they remain almost same. So that is a good thing, is that whatever major molecular response are achieved, they are actually durable. Now, the cumulative incidence of MR 4.5, that is deep molecular response by the end of 10 years. See, at the end of 5 years, nilotinib is able to achieve more than 50% of patients achieving this MR 4.5 as compared to only 31.4% in imatinib arm. And there is increased cumulative incidence of achieving this MR 4.5 by the end of 10 years. You can see that this 53.5 increased to 61% and 39.2, but at each point of time, the number of patients achieving MR 4.5 in nilotinib arms remains significantly higher than in imatinib arm. Now, something which we are scared in patients with chronic myeloid leukemia, because these patients are supposed to have near normal life expectancy, but something which is like progression to accelerated phase or the blast crisis, that results in very poor outcomes. You can see that the total number, the analysis done after the end of 10 years, the total number of patients who have progressed to accelerated phase of blast crisis is around 25 patients in imatinib arm, whereas 11 patients in nilotinib arm. And at the end of 5 years, means after 5 years, there are almost none of the patients, that is one in nilotinib arm, whereas in imatinib, still the patients are transforming into blast crisis or the accelerated phase. Now, but whatsoever the deeper responses, faster responses are achieved by second generation TKI, but the overall survival, there was no significant differences was seen in between the first generation TKI or the second generation TKI. Again, the fact that because of the near normal life expectancy of the patients of CML and multiple lines of therapy they can be offered. So this difference is not quite visible, but yes, a long-term data will surely be able to detect any significant differences between in these two TKIs. But yes, the total number of deaths due to CML were very fewer in the nilotinib arm as compared to the patients who have been treated with imatinib. So this is the clinical case follow-up of our patient. Our patient was initiated on nilotinib, that is 300 milligram BD, and she tolerated the therapy well. And you can see the BCR-ABL1 transcript that she achieved an early molecular response, that is a very good response than an early molecular response. And at the end of 6 months, better than a major molecular response, and MR5 at 18 months. Now, after 2 years of the therapy, now she expresses to have a baby, to conceive. So the motherhood is something for a female which one could not deny. So what will be your advice to her, that whether that the lady, you are having a blood cancer, so you are not supposed to leave the therapy, or at least wait for an additional year, or stop the TKI therapy, and then if after 6 months there is no recurrence of the disease, you can try to conceive. So there are certain confusing questions in our mind, that how to actually deal with the patient who have actually had received 2 years of TKI, how to go further. So these are the summary of the steering group recommendation derived from the patient-physician discussion, that who are the subset of patients who can be actually offered the treatment-free remission. What are those subset of the patients? So these are those patients who have actually had the therapy or TKI therapy for at least 3 years and 1 year of sustained deep molecular response, and are ready to be monitored intensively. So these are the patients where we can attempt a TFR. So in the INESTENT study, where the patient who met this stringent criteria for attempting treatment-free remission, they were in nilotinib arm, there was around 37.9% patient where we could actually offer this TFR trial, whereas in imatinib they were around 20% only where we can offer or attempt this TFR. So this is, there are, after the Twister as well as TIM2 studies, they have led to further studies in second generation TKI for the treatment discontinuation, that INESTOP and INESFreedom. These are the 2 studies which have actually addressed the TFR with the second generation TKI, nilotinib, in the upfront setting and as well as in the subsequent setting. This is the treatment-free remission following the frontline nilotinib in the patient with chronic myeloid leukemia in chronic phase. This is INESFreedom, where INESTOP is in the subsequent setting. Then what is the criteria? That is, patient should have at least 2 years of frontline nilotinib and has deep molecular response, that is MR 4.5, and this MR should be sustained for 1 more year. And if the patient is having sustained DMR, then patient can be attempted a TFR, that treatment-free remission. And these patients should be actually ready, should be actually counseled for very frequent or intensive monitoring with the BCR ABL1 as well as certain routine investigation, that is monthly for first year and every 6 weeks for the second year, and then later the frequency can be decreased. So this is INESFreedom study data that sustained the treatment-free remission was actually were being able to maintain in at least half of the patients who actually left or who actually discontinued the TKI, and the patients half who actually lost this response. Among that, after reinitiation of TKI, 98% of the patient actually regained the major molecular response, and 90% of the patient again regained the DMR. So the patient who lost DMR rapidly regained the molecular responses. As I said, that 98% of patients actually regained MMR, whereas around more than 90% regained MR 4.5. There are certain speculation about the safety profile of the TKI post discontinuation. There are certain non-specific and the musculoskeletal adverse event escalating after the TKI discontinuation, but that tends to be actually significantly reduced with the time. And adverse event that may have an adverse impact on patients' quality of life tended to significantly decrease in frequency over the time during the TFR attempting. So you can see that the gastrointestinal disorders, the infections, the musculoskeletal disorder, which were the most commonly seen non-specific adverse events occurring after the discontinuation of TKI, they tend to decrease after the TKI or discontinued, and the frequency was significantly decreased over time. So our patient went off therapy with monthly follow-up for 6 months and 2 monthly follow-up for 1 year. And just before lockdowns, she joined her workplace and now plays well. These are the reported adverse events with the nilotinib and imatinib. We all know that these two are well-tolerated TKIs. One is first generation TKI, the other is second generation TKI, but with the different toxicity profile. Imatinib is associated with the increased incidence of deranged liver function test, peripheral edema, fluid retention, as well as myalgias, whereas nilotinib is associated with certain transaminitis and other adverse events. Also, one more thing which was being seen, that nilotinib as compared to imatinib is associated with significantly increased cardiovascular events, but that can be attributed to the fact that the patients were not included in the trial based on Framingham risk stratification, and later it was been found that these cardiovascular events were more in patients who were in high Framingham risk group. So summary of the nilotinib is that nilotinib actually results in very higher and the faster molecular responses with a first generation TKI. And these major molecular responses and deep molecular responses were higher throughout the follow-up period, and they tend to cumulatively increase during the time period being followed. Observed 10-year all survival rates were similar because of the patients can be offered with the multiple lines of TKI we are having. Treatment-free remission following a minimum of 3 years of nilotinib first-line treatment combined with having a sustained DMR is safe and achievable. Around 50% of patients were able to maintain the DMR after 192 weeks, and the 50% who actually lost, they actually 98% regained after reinitiation of TKI, and out of which more than 90% regained the DMR. So it is safe. Treatment-free remission is increasingly seen as an important clinical goal for the patients, and the safety profile of nilotinib is well established, except for certain transaminitis, QTC prolongation, as well as the cardiovascular events. But cardiovascular events tend to be occurring more in the patient with high Framingham risk group. These are the indication of nilotinib. Except for the blast crisis, it is indicated in all the phases of chronic myeloid leukemia. So this is for treatment-free remission. So I finish my presentation here. Thank you. Thanks, Sachin. Thanks for the patient listening. So now the second, with this, I would like to invite my beloved senior Dr. Lieutenant Colonel Kundan Mishra to present a session on chronic lymphocytic leukemia. Sir, I am so fortunate to have you on this CME. Thank you. Thank you very much. Thanks, Sir. Over to you, sir.
Thank you, Dr. AP. Thank you very much for the kind introduction and this opportunity. Can I share my screen? Is it possible?
Yes, sir. You can share.
Yeah. Good evening, everybody. So today I'm going to deliberate upon the treatment of chronic lymphocytic leukemia. So the topic will be covered under certain headings like epidemiology and Indian scenario, the current approaches in management, the future approaches in CLL management, and I'll summarize at the end. So there are a few peculiarities of CLL, like it is commonest malignancy in Western world, commonest hematological malignancy. If you're talking about the leukemia, it's the commonest one in Western world, while it is the least common as far as Indian scenario is concerned. So there is it sounds very peculiar that if it is the commonest one in Western world, commonest leukemia in Western world, why it is the least common one in Indian scenario. So those of us who are working day and night with CLL will understand that the CLL is a relatively indolent disease, and that's the reason that patients are very well preserved and it takes time for progression. So many of the patients who have CLL will present with some other diseases, and they're incidentally detected with CLL, and most of the time they don't require any treatment for CLL also, even if we are diagnosing them. Like at present, I have about 70 patients of CLL under follow-up for me, and around 20% patients are on therapy, rest 80% patients are under observation only. So these patients, perhaps if they were followed up at some peripheral centers and all, they would not have been diagnosed with. So that may be the reason that as the therapy is not required, so diagnosis is also not confirmed in our scenario. That may be the reason. The overall survival, 7 years, is not bad, particularly considering the fact that CLL is a disease which is disease of elderly. Many patients of CLL, they have comorbidities, and more often than not, they die because of some other disease than CLL. There is considerable effect of gender, race, and geography, though many of them are not that very clear, I'll say. But yes, it is supposed to be more common in males, in Caucasian, and significantly lower in Asian people. The last but not the least is the familial incidence of B-cell malignancy. CLL is the one where the familial incidence has been reported as high as 10%. But again, that is the Western data. As far as our data is concerned, or a few more from India are concerned, which have been published, it has familial incidence, but I think it is in the range of 2 to 4%, not more than that. So a few things specifically regarding Indian scenario, I think the younger age. So the younger age, I always say that it is explained because the median age, the survival in the median age up to which Indians survive, it is around 10 years lesser than what the Western people have. So of course our patients' age will be younger in comparison to the Western people, but it is not that very young also. Most of the time patients are 60 plus. It has an aggressive course and a short follow treatment. So aggressive course, yes, to some extent, but that totally is driven by the kind of mutation you detect and the way you follow up these patients. This is one, I think this is the largest data which has been published from PGI Chandigarh, and around 409 patients were included from 2011 to 2017. And the important thing here to note was that chlorambucil was the commonest. Rather, in majority of the patients, they received only chlorambucil. 52.2% patients received only chlorambucil, and next best was BR, bendamustine rituximab, and around 31% patients received that. So these two together constituted around 84% of the treatment cohort. So why it is important and how the things have changed now and what should be done now, that is what we'll be discussing in today's lecture. So we'll start with the guidelines and then we'll go to the evidence behind that guidelines. So two important guidelines I'll be discussing. One is NCCN and the other is ESMO. So coming to the NCCN guidelines, the latest NCCN guidelines for CLL. So the treatment is dependent upon first thing which divides the treatment is presence or absence of deletion 17p or TP53 mutation. So if you take the patients who are without 17p mutations or 17p deletion or without TP53 mutations, the preferred regime for the treatment as first line as per NCCN now are acalabrutinib with or without obinutuzumab, ibrutinib, venetoclax, and obinutuzumab. So these three are the preferred ones in individuals who are frail or more than 65 years of age. And there's not much of difference when we consider younger individuals who are less than 65 years of age. Again, these are all oral, though it can be combined, though this acalabrutinib or venetoclax can be combined with injectable obinutuzumab, but the main stay is acalabrutinib, ibrutinib, and venetoclax. All three oral drugs with or without the injectable combinations, and they are the preferred drugs in patients who are without 17p deletion or without TP53 mutations, irrespective of the fact that whether they are young, less than 65-year age, or they are more than 65-year age, or they are frail, or they have multiple comorbidity. These are the preferred drugs now. If they don't get these drugs, then the other recommendations include what we have been using all the way, like I just discussed, the data from PGI, where 80% of the patients, they receive bendamustine and chlorambucil. So we can see that is the second line kind of therapy, or in first, they can be used in first line only with the preferred regimes of BTK inhibitors or BCL inhibitors are not available. So little bit, so it is this recommendation is totally different from what we have been using over the period, over the years. Means last 10 years, if you see our data, what we have been using in our clinical practice, not only in army, but even in prestigious institute like PGI Chandigarh, the things have changed quite a lot. And now the emphasis are on these oral molecules, these targeted oral molecules, and ibrutinib, acalabrutinib, and venetoclax are the preferred drugs in each group and subgroups of CLL as first-line therapy. If you are looking at the patients who have deletion 17p mutations, deletion 17p or TP53 mutations, then the preferred regimes will be acalabrutinib with obinutuzumab, ibrutinib, and venetoclax with obinutuzumab. So not much of a difference. It is almost same as it was in patients who had no deletion 17p. So things have definitely moved a little bit. Coming to the ESMO guidelines. So ESMO guidelines are somewhere how we used to approach a case of CLL till recent times in our OPD, where any patient of CLL who requires treatment, prior to starting of the therapy, we always used to look at the IGHV mutation. A patient who is IGHV mutated will be treated slightly different than the patient who is IGHV unmutated. So it sounds to be, the ESMO guidelines sounds to be more familiar for us. A patient who is having CLL requiring treatment as per the ESMO guidelines, IGHV mutation with no TP53 mutation, no deletion 17p, a fit patient, we can go for ibrutinib or even chemoimmunotherapy like FCR. And if patient is unfit, then venetoclax with obinutuzumab or ibrutinib or acalabrutinib. If a patient is IGHV mutated, and there is no TP53 mutation or deletion 17p in a fit patient, chemoimmunotherapy will be the first line like FCR, and ibrutinib can also be used. That will also be the first line only. And if the patient is unfit in this subgroup, then venetoclax, obinutuzumab can also come into the action along with ibrutinib, acalabrutinib. Chemoimmunotherapy is also one of the options over here, because a patient is IGHV mutated. So even in unfit patient, if possible, you can give chemoimmunotherapy. Perhaps bendamustine rituximab will be a better thing, or chlorambucil obinutuzumab, drug which will be slightly on the lower side. Sorry. So in third subgroup, where it will be TP53 mutated, am I audible?
Yes, sir.
Sorry for the interruption. Yeah. So we are talking about the ESMO guidelines on CLL management, the frontline therapy for CLL. So the IGHV unmutated and IGHV mutated group, deletion P, I just discussed how to go about it. And the third group is TP53 mutated patients or patients who have deletion 17p. So as per ESMO, all patients should receive ibrutinib or acalabrutinib or venetoclax obinutuzumab as first line. And role of chemoimmunotherapy is not much. It is almost universally accepted now that patients who have TP53 mutation or deletion 17p, there is not much role of chemotherapy or chemoimmunotherapy. So what about the relapse CLL patients? So if patient has TP53 mutations, almost similar kind of, if you have used ibrutinib before, then now you use venetoclax. If you use venetoclax, rituximab before, you go for some other drug. But overall, all these 2-3 molecules are there, including idelalisib, which can be used. And patients, once they relapse, and if they have TP53 mutations or deletion 17p, you can even consider allo stem cell transplant. That is something which we should keep it in mind, that a patient who is relapsing with TP53 mutation and patient is young, fit enough, has a matched sibling donor or even matched unrelated donors, allo-SCT, allogenic transplant is also an option and should be kept in the loop. A patient who had short remission duration less than 36 months, but without TP53 mutation and is relapsing, again, out of the 3-4 combination we have discussed, one of them can be used depending upon what was used before. We have to change it and use the other one. Patient who had long remission duration more than 36 months, there we can repeat the frontline whatsoever were used before, because patient had a long patient has a good favorable response. So overall, there is no role of chemotherapy or chemoimmunotherapy in deletion 17p or TP53 mutation. That is something we should be written boldly and underlined. So there is some evidence also for that, as you can see over here. On the left side, there is a curve for the overall survival, the Kaplan-Meier curve. We can see in the CLL8 study that where FCR has been randomized. There are patients with TP53 mutation, and we can see that patients who have TP53 17p deletion, there the overall survival at around 60 months, means 5 years, is less than 50%. Less than 50% survival, even despite getting FCR. So TP53 mutation or deletion P adversely affects the result outcome of FCR. However, if you look at the ibrutinib in TP53 ablation, we can see over here that the survival percentage, even with TP53, the 5-year overall survival was around 85%, and the progression-free survival was around 70%. So from less than 50% in FCR, more than 70%, more than rather 85% in ibrutinib is a sharp difference. So the frontline strategy for the TP53 wild type until 2018 used to be, for a fit patient, we will use FCR, the chemoimmunotherapy, and for moderately fit patient, we will use bendamustine rituximab. And for unfit patients, maybe you would like to use chlorambucil or even ibrutinib sometimes. However, the things are changing. Things are changing now, and this is the other report of FCR progression-free survival, which was decreased by unmutated IGHV. So it is not just the TP53. The IGHV mutation also significantly affects the outcome of FCR regime. We can see over here the 5 years progression-free survival in mutated patients are 66%. However, it comes down to almost half at 33% in the patients who are unmutated for IGHV. So FCR, when we are giving, we have to first look onto the TP53 mutation or deletion 17p. And if that is okay, that is wild type, then we have to again look into the IGHV mutation. If that is mutated, then only there is a subgroup of patients. If they are fit, they are younger, they have no comorbidities, then we can think of considering FCR, as it gives a long lasting remission. So even with 11q deletion, the progression-free survival in FCR is compromised, and we can see that a patient with deletion q presence, the median PFS was around 37 months in comparison to the overall patients when combined together. So not only the IGHV but 11q also affected the outcome of FCR significantly. Then unmutated IGHV we have already discussed. Then even first was the FCR, now the bendamustine rituximab, the BR. There also the progression-free survival is decreased if the patient is unmutated for IGHV from 55.4 months in IGHV mutated patients. The progression-free survival is 33 months in IGHV unmutated patients. So IGHV mutation significantly affects the outcomes of chemoimmunotherapy, whether it is bendamustine rituximab or it is FCR. So these are some of the trials which were conducted and published in journals like NEJM. So FCR versus ibrutinib rituximab was published. Then by E1912 trial. Then there was Alliance trial where ibrutinib was compared with rituximab, along with rituximab was compared with bendamustine rituximab, and the Illumina trial where ibrutinib was compared with chlorambucil. So ibrutinib obinutuzumab was compared with chlorambucil and obinutuzumab combinations. So we'll talk about each one of these trials subsequently, and then we'll see how the frontline therapy of CLL changed from chlorambucil or bendamustine or the FCR regime to the newly approved drugs, particularly from the BTK inhibitors group, and that made a marked change in the outcome of the patients. So the first we'll talk about is the phase 3 trial, Resonate 2 trial. We see here the ibrutinib 420 milligram once a day was compared along against the chlorambucil 0.5 mg per kg. And it was continued till progression of the disease was there, and previously untreated patients were there. This was for the first line. So all previously untreated CLL requiring therapy were included in this study. The age group of patients were more than 65 years, and the lesion 75P in this study at least were excluded. So going by the result of ibrutinib versus chlorambucil up to 7 years of follow-up, we can see that if you look at this graph, the PFS, there is a statistically significant difference in the progression-free survival between chlorambucil and ibrutinib. Ibrutinib is far on top in comparison to the chlorambucil, while in chlorambucil the PFS comes to around 10% or so towards the end of the study. In ibrutinib arm, it is in excess of 50%. If we do look at this graph, that which the subgroup analysis, and we'll observe that none of the subgroups, whether it is age, the staging at the baseline, the performance stage by ECOG of the patients, the bulkiness of the nodes of the patients, the high risk mutation like 53 mutations, deletion 11q, or the IGHV mutation status, or beta microglobulin level at the baseline. None of the subgroup analysis favored chlorambucil. Rather, even in the subgroup analysis, apart from the overall survival, the subgroup analysis also showed that ibrutinib will be preferred in each and every subgroup. If you will look at the progression-free survival by IGHV status, mutated or unmutated, the upper two curves, they show the patients with ibrutinib, whether unmutated or mutated. We can see there's not much of difference as far as PFS is concerned. In ibrutinib arms, IGHV mutations is almost negated. While on the other hand, in chlorambucil treated patients, there is an importance of IGHV mutations, and patients who were IGHV unmutated, they fared even worse. They fared even worse. Almost not even 10% patients were left over at the end of the study. Rather, total overall, there was only one patient, single patient, who was there without progression of the disease at end of the study. So while IGHV mutation doesn't affect much as far as BTKI or ibrutinib is concerned, it affects the effect as far as chlorambucil is concerned. So if we look at another subgroup of 11q or unmutated IGHV, you can again see that ibrutinib negates all these even 11q or IGHV mutation. Both are negated by the ibrutinib. In comparison to that, the chlorambucil arms, they fare pretty badly. Coming to another study, the Illuminate one, where the ibrutinib 420 milligram was compared with obinutuzumab and chlorambucil. So ibrutinib along with obinutuzumab was compared with chlorambucil and ibrutinib. So doublet on both the arms. Here the patients again were of 65 or more age, and deletion 17p mutations were included in this study in comparison to the previous one where it was excluded. And any patient who has a creatinine clearance more than 30 ml per minute, they're all included, and adequate hepatic, renal, and hematological functions were expected, as obvious. So when we look into this study and we look at this forest plot, we notice that even here, all the subgroup analysis, they preferred ibrutinib with gazyba or obinutuzumab, what we call. They all favored, all the subgroups also favored the ibrutinib and obinutuzumab therapy, and none of the subgroups they favored chlorambucil and obinutuzumab. So as we are looking into the study after the study, we are finding that not just overall CLL, but even the subgroups of CLL, the BTK inhibitors have been a boon. So looking at another study, the ECOG 1912 study design, here the ibrutinib was along with rituximab was compared with FCR, the one of the most useful regime before this BTK and all came. So now the ibrutinib along with rituximab took the challenge of FCR. So here also the patient with deletion 17p was excluded. However, patients with newly diagnosed untreated CLL were included. Rest of the patients with CLL were included. And once we look at the study of the study result, we notice that the PFS at 3 years in IGHV unmutated population, which as such fares very badly, the progression-free survival was 90% in patients who received ibrutinib rituximab. So very good result we can say in IGHV unmutated patients, and it was even better. It was much better in comparison to the FCR. However, if you look at the IGHV mutated population, the FCR group, they gave a full, I'll say that they were almost non-inferior to the ibrutinib rituximab. So this was one subgroup we always have been discussing, and in the ESMO guidelines also we noticed that young healthy individuals without comorbidities and all, if we want to use FCR, we must look into the IGHV mutation, and if the patient is IGHV mutated, we can consider FCR in these groups, because these groups, these are the patients where FCR is, I'll say, as efficacious as or non-inferior to ibrutinib based therapy. Looking at another study, the Alliance one, where bendamustine rituximab was taken over by ibrutinib, and as well as ibrutinib rituximab arms. There were 3 arms in this study, and all untreated patients. We are talking about the first line therapy, so all untreated patients of CLL were included, if age equal to or more than 65 years old, and the PS was 0 to 2 as per the ECOG. So here, if you look at again the subgroup analysis, we can see that the most of the subgroup, they all favored ibrutinib containing regimes than BR. And there was no significant difference when we compared the ibrutinib rituximab group with ibrutinib alone. So after this study only, this ibrutinib rituximab went out of favor, and mainly we started using ibrutinib alone. So if you are looking at progression-free survival by IGHV status over here, then we'll notice that PFS was longer with ibrutinib containing regime among patients with IGHV mutated than with unmutated IGHV, but there was no significant interaction with IGHV mutation status. So IGHV mutation status, even in this study as in the previous studies, showed that it doesn't affect the outcome as far as ibrutinib is concerned. So ibrutinib in first line in CLL, there are three evidence-based study we just discussed. And if you look at that, whether it is Resonate 2, where ibrutinib was compared with chlorambucil, Illuminate, where ibrutinib with Gazyva was compared with Gazyva and chlorambucil, Alliance, ibrutinib or ibrutinib IR or BR, three arms were there, or the fourth one, the ibrutinib versus FCR. So in all these four study, will notice that the arm which had received ibrutinib fared better than the arm which didn't receive ibrutinib. Only exception was the IGHB mutated subgroup in the ECOG 1912 study, where IGHB mutated subgroup fared very well even with FCR, and it was comparable. The result between IR and FCR were comparable. Otherwise, in all the studies, ibrutinib containing arms did better than the chemoimmunotherapy arm. So to conclude it, ibrutinib has shown better outcomes than chemoimmunotherapy in unmutated IGHV. It is also non-inferior outcomes in mutated IGHV. So this is as far as the first line therapy with ibrutinib is concerned. Coming to the next BTKI, which is the acalabrutinib, and how it fares in the previously untreated CLL. Let us see that. So the trial is Elevate PN trial. So here the patients with previously untreated CLL were randomized into 1:1:1, and they were further stratified based on the 17P status, ECOG-PS, and geographical region. So they received one arm received acalabrutinib with obinutuzumab, second arm received acalabrutinib monotherapy, and the third arm received obinutuzumab with chlorambucil. If you look at the median age in these three groups, all the three groups, it was 70 and 70 in the acalabrutinib arms, while in chlorambucil arm it was 71. But overall, if you look at it, these three arms were very well balanced, and they were no any subgroup had excess of any mutation or other say poor performance status and all. Like if you look at the 17P deletion, 10, 9, 9 were equally distributed among all the three arms, even TP53 mutations, 12, 11, and 12. So they were equally distributed, very well balanced arms were there. And if you look at the PFS, so 90% risk reduction in disease progression or death with acalabrutinib plus Gazyva were noticed in this study in comparison to Gazyva chlorambucil. So chlorambucil based arm had around 47% PFS at 24 months in comparison to 93% in acalabrutinib arm at 24 months. So acalabrutinib, even when used alone, has a 80% progression-free survival at 28.3 months. So at the time of analysis, the number of events of disease progression or death was only 8% for acalabrutinib and Gazyva group, 15% for acalabrutinib monotherapy, and 53% for chlorambucil Gazyva group. So the acalabrutinib subgroup were more than 100% better in comparison to the chlorambucil arm. If we look at the improvement, if you look at the result across the subgroups, all the subgroups like we saw earlier, when ibrutinib was compared with the chlorambucil, even when acalabrutinib Gazyva was compared with the chemoimmunotherapy of chlorambucil Gazyva, each and every subgroup, whether it was RAI stage, sex, age, ECOG performance, or bulky disease, all of them, they favored acalabrutinib arm. The 17P deletion subgroups, the 11 the deletion 11 patients, the IGHB mutated or unmutated, the complex karyotype, all these subgroups also, they all favored acalabrutinib. Was there some significant adverse events related with the acalabrutinib arms? The answer is no. The most common adverse events were all grade 1 or 2, which were easily manageable. The serious adverse effects, however, of all grades occurred in around 39% of patients treated with acalabrutinib Gazyva and 32% with acalabrutinib monotherapy and 22% in patients treated with chlorambucil Gazyva. And death due to adverse events occurred in 4 patients in the acalabrutinib Gazyva groups, 6 in the acalabrutinib monotherapy groups, and 11 in Gazyva chlorambucil group. So overall, the adverse events were also not much, particularly if you look at the acalabrutinib monotherapy arms, and we look at the bleeding, which has been one of the area of concern when we have been using ibrutinib. We will notice the grade 3 or more complications were reported in only bleeding were reported in only 2% of the cases. So only 2% of cases had this bleeding tendency, diarrhea, which has also been a clear of region of concern with ibrutinib, fatigue. A lot many patients used to complain of fatigue, but it was insignificant in acalabrutinib arms. Upper respiratory tract infection was hardly, it was 0% in acalabrutinib monotherapy as far as grade 3 was concerned. On grade less than grade or equal to less than grade 3 were around 18%. So grade 3 toxicity were very minimal with acalabrutinib monotherapy and even when combined with Gazyva. So what will be the future approach for management of CLL considering all this data? So those CIT, the chemoimmunotherapy regimes have been the mainstay of treatment until recently. Now the time has come when the BTK inhibitors or BCL2 inhibitors will take over the lead. And future approaches will be something like ibrutinib, venetoclax, or novel therapy, the triplet combinations, like something like ibrutinib, venetoclax, and Gazyva. Then even CAR T-cell therapy is coming. The ibrutinib can be combined with the FCR, half of the FCR, means FC and Gazyva regime, MRD guided treatment. These will be the things which will be on top priority in the time to come. So a little bit regarding ibrutinib with venetoclax, one of the most important and most potent combination therapy for CLL at present. So this was the phase 2 captive study where patients received 3 cycles of ibrutinib followed by ibrutinib and venetoclax. I'll go a little faster now because I'm running out of time, I believe. So if you look at what was the benefit of this first 3 cycles of ibrutinib was that the risk of TLS came down drastically in patients who were given a lead with 3 cycles of ibrutinib. That is something I would like to inform all of you. Apart from that, if we have used this combination, the peripheral blood, the MRD undetectable was there in 75% of the patient, and even on bone marrow, 72% of patients when used ibrutinib venetoclax, they were MRD negative. So disease-free survival in unmutated MRD, even without treatment on all patients fared very well in this subgroup. So I'll not go into the MRD or adverse events, there hardly anything. So the main conclusion from the Captivate MRD cohort was that ibrutinib and venetoclax in all an oral once daily chemotherapy free fixed duration regime that provides highly concordant deep MRD remission in bone marrow as well as peripheral blood as first line therapy for CLL, a very promising therapy. The ibrutinib venetoclax, there are multiple trials which are going on. I'll not right now all of them. As far as the novel triplets are concerned, as I discussed, there's something like ibrutinib, venetoclax, and Gazyva can be used in the future. Though triplet has not been, all the triplets, none of them have been proven to be far superior to the doublet till now. So I'll not go into deep as far as triplet is concerned. Right now we are at doublet only. One line regarding the ibrutinib, FC, and Gazyva trial. Though seems promising, but adverse events and all multiple things needs to be looked into that. It's going on. Once the result comes, we'll look into that, how it fared well. But it is also an MRD driven trial where if MRD will be negative after 12 cycles, the ibrutinib will be stopped. And if MRD is positive, ibrutinib will continue, though venetoclax and other drugs will be stopped before that. So the IFCG has 89% of MRD negativity. So that's a promising thing, but then the side effects and other things we have to look into. So yeah, the CAR-T, last word is about the CAR-T. As we know that we have developed now indigenous CAR-T therapy in India, though it is at a very small level presently, but I do hope that it will come up in a big way in the time to come, and we'll have some CAR-T for CLL as well. So it will be another promising thing. We must keep it in mind. And as far as MRD guided treatment is concerned, we all must pull up our socks and get ready for the MRD things. Though I know that CLL MRD has not been optimized, at least in our centers, but we in our center are looking into this, and I am sure that in our country also people in the time to come will be giving emphasis on MRD guided treatment and patients the excuse me. And the aim in patients, particularly those who are young and fit, the aim will be to assess MRD and continue treatment accordingly. So the monotherapy or combination therapy in frontline both are okay, but something like venetoclax and ibrutinib combination have really been far more superior than any monotherapy or any chemoimmunotherapy. So that may be the future. And 3 drug combinations, I think it will take some more time. So more data should come because safety is a concern, and whether it will be better than the doublet, that needs to be seen. And MRD, yes, a big thing. So ibrutinib would remain the cornerstone of current as well as future regime, whether ibrutinib or even maybe acalabrutinib, one of the BTKI will remain the cornerstone of current as well as future regimes in CLL. And it seems to be as if monitoring MRD will become more and more common in CLL. So that's it from my side. Thank you very much.
Thank you very much, Dr. Kundan. It was a very extensive talk, and you have covered each and everything in the treatment of CLL. And I think just one question I want to ask: what is in your practice you are using in the treatment of CLL? Ibrutinib?
Sir, to be very frank, our approach has not changed much. We still in the younger individuals, we are still going with the FCR, young fit IGHV mutated patient. We are still using FCR, and in patients who are again IGHV mutated but not that so very fit, we are going for BR if possible. And we are keeping for patients who are TP53 mutated or deletion 17p positive, or patients who are very frail and all. So we are still giving some weightage to FCR and BR in our centers. Maybe in time to come, as the world is changing, we'd also like to change this.
Thank you very much, Kundan. It was a very nice talk. And we'll move on to the next session. And for that, it's my proud privilege to invite Dr. Rajan Kapoor. He is the hematologist and a very renowned hematologist, I must say, and presently at Calcutta. It's a pleasure to have you, Rajan, in this board, and he will be conducting, I think, both the session on both the panel discussions of CML and CLL. Dr. Rajan, you can start. You are not audible, Rajan.
Oh, sorry. So am I audible, sir?
Yeah, now you are audible.
Thanks a lot, sir. It's great seeing you in person, and I have a very, very long and very memorable association with Kapoor, sir. I'm the POOR, poor one, while he is the rich Kapoor. So that's how it goes. So, and it's a pleasure and it's an honor to be on the same platform as you.
My pleasure also.
And great to see both Kundan and AP both looking smart and dashing in Delhi. And with Kundan around, we know that army hematology is in good hands. And same with Dr. Dubey, who is a very, very dear, I can say, a student of mine. But
Sure, sir.
And he's doing so well, and it gives me an immense pleasure. So on to this session, as both Kundan and AP both have covered extensively everything. So I think the final comments will be left to them, but we have very eminent panelists. So Dr. Swami, is he there? Yeah, Swami.
Good evening, sir.
Oh, good. You are in India or in Canada or something? Like,
Sir, I'm still in India.
you're still in India. So great seeing you. And Dr. Megha Verma.
Yes, sir. I'm here, sir.
Hi, Megha. Good, nice
Good
seeing
evening.
you. Good evening. And Dr. Bhaskar Bhuvan
Yes, sir.
from Isaac.
Yes, sir. Hi, sir. Hi.
And Dr. AP and Kundan. So I'll start sharing my screen. Is it visible? The
Yes,
screen?
sir.
Yes, sir.
Yes,
Yes,
sir.
sir.
Okay, so this is a very simple like case-based discussion, though there are few slides, but I don't think so we'll be requiring those many slides, which is extensively been covered. But I will just, for the panel's sake, we'll start doing. So we have this case, a 43-year-old gentleman who had presented with weakness and fatigability, 3 months, hemoglobin of 13.4. WBC of 2.2 lakhs, platelet of 3.5 lakhs, spleen was 15 centimeters below the left costal margin, and there were 5% blast. Bone marrow was hypercellular, Philadelphia positive in all the metaphases, and BCR-ABL was T%. The SOCAL score calculated was intermediate risk, and he had history of asthma, which was controlled on inhaler. So just a quick question to Dr. Megha. We still do bone marrows in CML if we can make a diagnosis with PCR?
So we do prefer, because karyotyping we can do only by bone marrow. That is the only indication probably which is now left for in CML for the diagnosis part, to look for the additional cytogenetic abnormalities and for the baseline fibrosis.
Yeah. So that's very well said. Actually, though they say that a diagnosis can be made on BCR-ABL, but additional cytogenetic abnormalities. So there are major root and a minor root abnormality. So if they are present, then probably we'll be having to treat them more like an accelerated phase or a higher risk. And as she has said, if there is fibrosis, some of them do not tolerate these TKIs very well. So we may have to start at a lower dose. So yes, teaching for the residents definitely would be there, that even the diagnosis is easier to make, we should still do the bone marrow. For Dr. Swami, what would be the choice of first line therapy in such a patient?
Sir, patient is in intermediate risk and he seems to have respiratory problems. So in this patient, I would like to either go for imatinib or nilotinib, or even bosutinib. Apart from dasatinib, I am happy with all the other 3 options.
So can you just tell me, so if the finances are not an issue, let's put it this way, if the finances are not an issue, what would you start in this patient?
If finances are not an issue and we want a deep molecular response, so that we can think of treatment TFR and then stopping the drug. So in such situations, keeping these things in mind, I would like to go for either nilotinib or bosutinib.
Okay, so what is your experience with bosutinib? Because frankly, most of us have not used it.
No.
Okay, so I really don't know. Any other panelist, Dr. AP, have you used bosutinib?
No, sir. Dasatinib I have used, sir. Bosutinib I am yet to use, sir. And dasatinib also too much cytopenias.
I guess I don't know. I don't have a personal experience of bosutinib, so
I've used it in one patient, sir, who was triple refractory. So we have no option. He has no match also. So
okay.
we used it for a couple of months with the help of medical representatives and even little bit of expenditure from his side, because you couldn't buy it in time. But one patient only, well tolerated. There are not much of side effects as in any other TKI.
Okay.
So, but not much, sir.
Okay, but it did work. So because it's good to share this, and somehow I don't know when others, we used to use pegylated interferon, but somehow it's not available in the market. Any experience of Kundan? Are you getting peg interferon?
We are getting, and I think even as of today also at least 3 to 4 patients are there on.
So I'll probably take note from you,
maybe
because
some of them would have been started since your time only.
Yeah, but we are not getting it any longer. So that's a very valid point. Nilotinib can be used. And would high risk score have impact on the choice of first line therapy? Dr. Bhaskar?
Yes, sir, definitely, because usually with the risk increases, the chance of getting progression also increases. So he's a young guy, so we have to target more for his better response rates, and molecular response should be good in such kind of patients. For high risk patient, usually I'll go with the second line TK rather than first line TK.
So, but this patient was started on imatinib. Now, he achieved a complete hematological response by 2 months, and PCR at 3 months was 22%. Patient was compliant and he had GI disturbances. So now, for again, Dr. Megha, how in your practice, when do you do the first BCR-ABL after
So
starting?
we'll do it at 3 months as it is recommended by the ALN guidelines. And with the current picture, if it is 22%, so it is like early molecular, it's more than 10%, which we aim. Less than 10% is what we aim at 3 months. But if it's that much, then either we can do it and we can repeat the test after another month, check the compliance, and if it continues to be more than 10%, we can look for the TKD mutations and probably switch the patient to a second generation TKI according to the TKD mutation analysis.
Right. So very well said. So now the main thing is the first 3 months, how the BCR-ABL is declining. Actually, they have started doing it at 1.5 months also, but it remains that if it is more than 10% in 3 months, then definitely it makes a case for doing the TKD mutations and changing over the therapy. So this is a paper which came in JCO. So it clearly says that 3 months, that is the main target which we should, when we start monitoring the CML cases on imatinib. Again, the same thing is in multiple papers, the same thing now well incorporated. I think most of us are doing at 3 months with the free availability of BCR-ABL. Now, again, at 4 months, it is 20%. Now, what will be, Dr. Dubey, what will be your therapeutic strategy? Maintain imatinib, increase imatinib, or switch to a second generation? I think it's very
sir, BCR, now patient not able to achieve early molecular response at 3 months, and after 1 month, it is still persisting, not able to achieve early molecular. So we'll label it as TKI failure. We'll do TKD mutation and switch over to the second generation TKI, sir.
Okay. So, Dr. Bhaskar, how often are you getting these imatinib resistant mutation analysis, which we were saying, like which technique are you following?
Sir, actually, yeah. So in majority of my patients, 95% of the cases, usually we don't have any resistance kind of thing, but 5% of the cases we may see the TK failure. I'm not sure about the kind of mutational analysis, but usually we'll get the IRMA testing, but I don't know the method exactly.
Okay, PCR. So again, the same thing which has been told by everyone, that failure, you consider if it is at 3 months, more than 10%, rather than wasting time, you should prompt a person. And Dr. Kundan would I'll ask you, if there is a young person in our country, supposingly we do start on second generation TKI, would you prepare them for a transplant or not?
Sir, any patients who has any young patient who has an issue with the imatinib to begin with, we always prepare those patients for the transplants. Yeah. Whether it is cytopenia, whether it is imatinib resistance, whether it is kind of advanced stage disease, whether it is fibrosis, all these, any slightest of the abnormality in a young fit patients, we always prepare them for the transplants.
So this is very important. You may not get clear cut in guidelines, but in our country, transplant still is an option in CML. Please remember, CML is one disease which is very amenable to allogenic transplant. Graft versus leukemia effect is fantastic. DLI works the best in CML. So any young person not achieving milestones, get a match done and prepare him for transplant also. So this, I'm not going to delve on this. So now this is very important, which had been eloquently told by Dr. Dubey about MR 4.5, which is the target now. So when we switch over to nilotinib versus continuing imatinib, you can clearly see that higher portions without MR 4.5 do achieve MR 4.5. So again, same thing. I guess there's no guesses for this. There's no point in continuing the same dose. We'll shift to the second generation TKI. Now, the same thing, bosutinib, as we said, we hardly have any experience. Dasatinib and nilotinib are the two ones. Now, dasatinib is gaining favor because of the availability of a generic, which is the cost becomes a factor. Otherwise, dasatinib and nilotinib, not much to choose other than the usual side effect profile which we see. Dr. Swami, why imatinib? Why don't we give a higher dose of imatinib? Just increase the dose which we used to do it, 400 BD and on with the patients too.
But if you look at this case, he is already at 600 mg only. He is already developed a symptoms, and also he is it is a failure. So inferior outcomes in such situation if we continue imatinib, but because of poor tolerance, definitely we need to switch to.
Yeah. Now this is a question which is generally asked, Dr. Dubey, how to select the second. Now you have two at least, not bosot. If we take out the bosutinib, how will you select in imatinib resistant or intolerant?
So it based on, sir, TKD mutation, affordability, availability, and the toxicity profile. So these are the things which I will see while prescribing a subsequent line TKI, sir.
Yeah, so TKD mutation, we all know the graphs. The most dangerous one is T315I, but I hope that with the help of Novartis, we soon will have an access to asciminib at least. So asciminib has shown some effect. It's a STAMP inhibitor which has shown some effect. Ponatinib somehow we have not been able to have a free access to it, but this is the one mutation which we are all worried about is T315I. We hope that in the coming years we'll get access to asciminib.
Sir, can I add one more point? Actually, patient preference, whether they will take once a dose or twice a dose, the tablet also important in keeping the compliance. Okay, so
yeah, and with the meals, and whether the time,
because majority of the patients prefer to take once a day tablet rather than twice a day, like nilotinib is BD, remaining things are body tablets. Okay, so some patients prefer in based on this criteria also.
Definitely. But yes, the comorbidity, someone having pneumonia, pulmonary arterial hypertension, pleural effusion, definitely I'd like to go in for an nilotinib, and vice versa. If QT is prolonged, we go in for dasatinib. So this was a case F317L. So we have already discussed what are the major things. So nilotinib was continued in this, and at 6 months it was 1%. This has been already covered, TKI cessation. So, Dr. Dubey, if supposing in such a case, can you make a case for TKI stopping the case who had progressed on imatinib, so CAL intermediate to high risk? Would you recommend a TFR trial in this?
Yes, sir. There's a INES top study, sir, which has actually shown that very good TFR at even at 192 weeks. But the patient should be at least on 2 weeks or 2 years of nilotinib followed by 1 year of sustained deep molecular response. So these patients can be offered a trial of TFR, sir.
Yeah, so I have been more conservative in this. Normally, I don't know, Kundan is there. So we have, whatever we have selected a patients who have done well on imatinib, if they have done. We have never tried imatinib who has progressed on to nilotinib and then went on TFR. Kundan, do you have any such case?
As our departmental protocol, we are not taking patient in TFR if they are on second line.
Second line, yeah. I don't know. So that becomes a little difficult, but yes.
Because most of the studies where patients have been on for TFR have gone for TFR on second generation. They have been those who were started on second generation.
So it's a different people who have progressed on to imatinib and then gone on to second generation. There are very few studies who say that TFR can be attempted because it's a little risky, I would say. So this has already been discussed. So now this is just a simple thing which I had this case which has been so Dr. Nair, we can see she's a 32-year-old female who had splenomegaly and found to have it's confirmed to have a CML. So what would you suggest for this lady?
So
she is a low risk and wants to know effect of disease and its treatment on her future plans for pregnancy. She has
So
come to your
as
opinion.
in this case, it's a young lady who's been diagnosed with CML, with a low risk disease, and her aim is she's looking ahead for pregnancy. So our aim would be TFR, to achieve a TFR at earliest. So we shall be starting it on a second generation TKI to attain our goal of reaching deep molecular response sooner.
Yeah.
So with that, we should start. And once 3 years of at least minimum 3 years of TKI, with if we can attain 2 years or at least 1 year of deep molecular 4.5 or so of deep molecular response, we can plan for the TFR trial.
Yeah.
So
That's right. So Dr. Bhaskar, have you got any experience of pregnancy with imatinib?
So personally, I didn't do, but when I was a resident in RDR, that time 2 patients were gave TFR trial, but they were actually received imatinib. After that, we had given TFR because they continually for more than 1.5 years, they were in remission, actually major molecular response. So but with the second line drugs, I never had any experience.
Okay, so what Dr. Megha said, absolutely right. This is what we should do, but we have been doing like with imatinib also. For the first 3 months, we have shifted over to pegylated interferon during the first trimester and then restarting imatinib. That's a poor man's choice if you are not having an excess and she still wants to become pregnant. And till now, we've had cases continuing imatinib in the pregnancy, and touch wood, we haven't had any teratogenic effect. So there is one study which say that even imatinib does not lead to that much of teratogenic effect. So poor man's thing is, for first trimester you can shift over to peg interferon and restart on imatinib. But yes, if you have access to nilotinib, I think that would be good. This would end the CML, and then I think we'll just go on to and this has been very eloquently discussed by Kundan, so we won't have much of a problem in so we'll have 3 case scenarios. So this is a typical 74-year-old elderly gentleman who is presented with lymphadenopathy and has got comorbidities like hypertension, cholesterol, and BPH, extensive bulky nodes in neck, axilla, and groin, lymphocytosis, hemoglobin is 11, platelet is 1 lakh, marrow is 70% replaced with CLL, fish testing reveals del11Q, and IGHV is unmutated. So my question to Dr. Swami is, would you treat this patient?
He is a symptomatic patient, so symptomatic with?
No, he had just the bulky nodes. He just first found the nodes. You did the test and you found this.
Okay, sir. If it is asymptomatic and if the lymph nodal sizes are less than 10 centimeter, and if splenomegaly size is less than below costal margin, if it is less than 6 centimeter, we will keep him under observation.
Okay.
If he has any symptoms, then we would like to initiate treatment.
Okay, very well said. And even the marrow is generally not required. So we have to remember that even if the fish testing reveals anything, some people do not do it at diagnosis or IGHV status. The indication for treatment is clinical. So if there is any development of cytopenias or extensive bulky disease, which he has said, or sometimes a rapid lymphocyte doubling time, CLL may not require treatment. But whatever said and done, each and every drug has its own side effects.
But sir, this the particular patient you have shown, sir, that this patient required treatment, sir.
Why do you say so?
So the largest nodes, 12 centimeter in mesentery.
Yeah. So this is one thing, that the node is more than 10 centimeters. That's why this would require, but be very firm that most of the patients generally present with anemia or thrombocytopenia. That is the time when required. But bulky disease, rapid lymphocyte doubling time, or immune paresis may also require the treatment. Are there any additional tests to be done, Dr. Megha?
IGHV and fish we do except that I would like to know the baseline kidney functions, the creatinine values, baseline echo, the patient, or ECG echo, because the patient has 74 years old, has a history of hypertension. So for choosing the therapy, I'd like to, except assessing his performance status, like to do these tests.
There's a lot of, I mean, most of us want to do a PET CT scan. So what is your
Yes,
view
sir.
on
So a
this?
radiological scan, a radiological scan was, I think, done in this
Yeah,
patient.
then I'm asking, is there any role of a PET CT scan in a CLL?
CT scan per se, CT of chest, abdomen, a low dose CT shall serve the purpose.
Yeah.
Only in case if we are suspecting a transformation, like the patient has developed acute worsening of B symptoms, then we would like to do PET CT for a guided biopsy to prove the diagnosis.
So that's very important. If you are suspecting a Richter's transformation, to see which is the best node. If the SUV is more than 10, that is the lymph node which you should target for detecting a Richter's transformation. So, Dr. Bhaskar, how will you manage this patient?
Sir, actually, this patient is elderly, 74 years. So he's right now his indication for treatment is there because of 12 centimeters, as Dr. Dubey told. So either we can go with so ibrutinib or bendamustine rituximab, maybe low-dose benda, because I'm not very sure of ibrutinib also because of his age and cardiovascular risk factors like hypercholesterolemia, something you showed, I think. So probably bendamustine rituximab is safe to me relatively.
Dr. Kundan, how will you manage this patient?
Sir, we have both options in this case.
Unmutated, no? It's IgHV is unmutated.
Oh, okay. Sorry. Yeah, unmutated.
Unmutated patient, it will be better to use BTK in this patient.
BTK, I think, ibrutinib is one which we have got the maximum experience with, though the risk of bleeding and other things are there, but it's better to start. And as Kundan had told, there is no point in adding on rituximab to ibrutinib upfront. So ibrutinib alone as a standalone drug would be.
So my doubt is that atherosclerotic disease is also okay with ibrutinib to use, because
it per se is not a contraindication. Only people who are on oral anticoagulants. So that is the time when the bleeding is a major risk. Yes, you have to be on a watch for this, but BTK inhibitors, acalabrutinib can be used as a first line, which has been used, but the maximum experience I would still say is
ibrutinib. Yeah.
And sir, arrhythmias also, sir, we don't usually.
Because usually cardiac arrhythmias and atherosclerotic
atrial fibrillation. Yeah, atrial fibrillation, you have to be guarded. ECAL, again, the issue with ECAL is taking twice a day. Headache is a major issue with acalabrutinib, initial at least for a month or so. So any of these, but ibrutinib is the one which we have maximum experience. So this is, I'm not going to delve into it, which has been extensively covered by Kundan. So again, obinutuzumab versus rituximab. Obinutuzumab, frankly, does not give too much of an advantage over rituximab, if you ask me. But yes, that's another option which can be combined. We'll discuss with venetoclax a little later. This has been already shown, ibrutinib with chlorambucil. Resonate 2 was extensively covered. Now, these are the adverse events of interest in ibrutinib. So atrial fibrillation, major hemorrhage, and hypertension. Hypertension actually is an issue with ibrutinib when you start. So you have to closely monitor. There your skills as an internist comes. So you have to closely monitor and modify drugs. Not that it cannot be controlled. And the other is using it with oral anticoagulants. So many of the patients are on DOACs. So that is the time when the bleeding risk actually increases with ibrutinib, which you have to be careful on. So this is another case. Now this is a 48-year-old male, no comorbidity, no prior medical history, fatigue, cervical lymphadenopathy, lymphocytosis at 40 years. Now he has got anemia, platelet count is below 1 lakh, serum LDH is 200. Now he's got, on progression, he had lymphocytosis, IgHV is mutated, no TP53 mutation, and del 13q by FISH. So, Dr. Dubey, how will you manage this patient? He's a 40-year-old.
So this patient is young, patient is symptomatic,
Yeah.
and the patient is having B symptoms, patient is having cytopenia. I hope they are not autoimmune, but I'll consider it as disease-related cytopenia. And patient is IGHV mutated. So I'll go with the chemoimmunotherapy in this patient.
So if supposingly I say that the finances are not an issue and all the drugs which have been discussed are available to you, would you prefer giving any novel therapy over chemoimmunotherapy?
No, sir, because the young patients, sir, and IGHV mutated patient, the fixed dose drugs cycles, and they'll be these patients. They are patients who will achieve durable responses for very longer times, and there might be some possibility of cure also in few patients with the chemoimmunotherapy. So, in particular, in IGHV mutated patient, I'll be just slightly reluctant on using BTK.
Which chemoimmunotherapy would you use in 40-year-old?
FCR, sir. FCR if the patient.
Kundan, any difference in opinion?
Yeah, I respect what Dr. Dubey said, but I'll differ a little bit. The issue is that the issue with the FCR we have to understand is that if a patient is young, we are deliberately saying that patient is young, we want a long-lasting cure and all those things. We have to consider what is the rate of secondary malignancy in these patients if you're using drug like FCR and all. So in these patients, if availability is there, finances are not an issue. Definitely a fixed duration therapy will only be good, because I cannot say that you take the drug lifelong. Something like venetoclax ibrutinib combination will be a very nice one, where the MRD directed therapy can be given, and over a period of time, even the drugs can be stopped and patient can be followed up.
So this is very important. I would agree with Kundan that in now the days of chemoimmunotherapy are numbered in CLL. In CLL, which was never heard of, which can be achieved. Though yes, most of our cases we are using coming couple of years or so, we probably will shift over to BTK or a BCL2 inhibitor or a fixed duration therapy. Now, where it said FCR definitely scores over BR, and again, this has been already shown. Now, will said there is no hello.
तो शायद सर नेटवर्क इश्यूज है सर आपके एंड पे.
I think. Hello. I think can you hear?
Sir,
hello.
Sir, your voice is breaking and the screen is frozen.
Okay, I'll just join again. Can
Yes,
I?
sir.
Yeah,
Yes,
I
sir.
think I won't show the slides. I'll just stop my video. Kundan, can you hear me?
Yes, sir.
In which scenario will you use rituximab along with ibrutinib? Rituximab with ibrutinib.
Sir, in which scenario specifically will use this?
Autoimmune hemolytic anemia.
Yeah, I think
So
that's
there even I can use methylprednisolone if I feel
yes.
like prednisolone, methylprednisolone.
In younger patients, sir, there are some studies. I don't remember the studies which have shown improvement in response rate as well as PFS. No improvement in overall survival. I don't know. I'm not like maybe.
So what he has said that supposedly if there are autoimmune cytopenia, it's always better to give steroids along with rituximab. Whenever you start ibrutinib, there is always a rebound lymphocytosis. That all we should be prepared for. So normally, if there are autoimmune cytopenias and there is an indication of chemotherapy, then you can give steroids along with it. So the other case, what is the relapsed refractory setting? So what is the choice in a relapse after an FCR, Dr. Dubey? Supposing you have used in a patient and after FCR there is a relapse. So what are the tests which you will repeat at the time of relapse?
What are the tests I'll repeat, sir?
Yeah, supposing CLL was there, the same patient, del 13q,
Yes,
and he has relapsed after FCR cycles.
sir, if the patient has already has received chemotherapy, then that's FISH CLL panel for 17p and TP53 dysfunction. Our TP53 mutation, I'll repeat for the patient, and I'll offer the patient BTK inhibitors.
BTK, yeah. So that in the relapse refractory setting also, as Kundan had thought, the treatment almost remains the same. If you have used chemotherapy, you can use a BCL2 inhibitor, ibrutinib or acalabrutinib. If you have an access to venetoclax, that can be used. So Kundan, any experience of a allogenic transplant in CLL?
Sir, two of my patients underwent CLL, transplant for CLL at PGI. One had 17p along with 11q deletion. The young lady, 35-year-old, we arranged somehow ibrutinib and venetoclax for her, and thereafter she underwent transplants. But again, she relapsed. I think, if I remember, within 12 months. So, and the other patient who was around 40 years old, that patient after about 2 years also was in the CR only. So not much, only 2 patients I have seen CLL being transplanted. I'm looking forward here in RR, but in last 3 years we have not got any such patients, suitable patients whom we could transplant. So whatever I have reviewed and seen, though that is an option, and particularly maybe in our setting, it is a very a strong point. It is favored in many patients. But I think that result in CLL is not that very nice as far as allogenic transplant is concerned in comparison to CML and all, where I always look forward, and every year we are transplanting a few patients of CML. It is not that very well with CLL. This is what I feel. It's very difficult to transplant them also. Am I not audible?
Sir, you are audible. Sir is not audible.
Achha, okay.
I think because we are talking about CLL, you have to take over.
Oh, sometimes it happens. So sometimes the dichotomy, see, we are only talking about all the molecules, inhibitors and all these things. And I also strongly feel that these molecules and all are very nice. And the logic to it, rational also, and results are also favoring. But in, you see, in our practice and all, we are...
real setting.
This is totally different.
Totally
different. And people still consider CLL to be a CLL is chlorambucil. I think last month only one of my patient has been started on chlorambucil prednisolone. And it's
no,
okay.
chlorambucil still remains an option for us in elderly, rather than as we had been brought out multiple comorbidities. Chlorambucil still is a drug which can be used. Actually, I just gone for an exam today at AIMS, so there no one had written chlorambucil for CL. So that was one point which Dr. Pankaj and we brought out. So great. I think it was very interactive and good to interact with all of you. And I think we have finished. Nothing else to share. Fantastic session.
Thank you very much, Rajan. It was a very exclusive discussion on panel discussion on CML and CLL, and I myself has got more educated now, especially in the treatment of CLL. CML, of course, I was aware of most of the treatment, but CLL, yes, the latest one. And but in practice, we hardly use so many drugs in CLL, and we keep most of the patient under observation. And of course, ibrutinib remains the cornerstone for most of the patients for the treatment of CLL. It's a great update, and I must congratulate Dubey for organizing such a wonderful evening. And I was present throughout the session because it was so interesting, and I never wanted to leave. And I must congratulate Dr. Kundan for a very extensive talk on CLL, and it's a pleasure to interact with you. And of course, Rajan, my good old friend, he is always good in his interaction, and he conducted the panel discussion very well.
Thank you, sir.
My congrats to all the panelists, because they have contributed a lot in the discussion, and we probably, as me, everybody must have gained few things from this interactive session. And I thanks each and everyone, and even the organizers, for conducting such a great event. Thanks a lot.
And
Thank you,
special
sir.
thanks to all my
Thank you,
panelists,
sir.
Dr. Swami, Dr. Megha, Dr. Bhaskar, and dear Dubey and Kundan, all of you. Thanks a lot.
Thank you so much, sir. Thank you so
Thank
much.
you, sir. Thank you,
Thanks, sir.
sir.